Echocardiography on ECMO, a very important subject in the post-COVID-19 period, when the pandemic has showed us that with the rising use of ECMO, most ECMOs failed in COVID-19. And one of the things that we learned at AIMS in the second wave of COVID-19 was that we need to monitor and do a great surveillance of the cannulas during ECMO. And not just the cannulas, but the formation of so many complications on ECMO. And echocardiography, therefore, plays a very important part. The organizers at this great Dubai conference are to be thanked for bringing home a very important part which most ECMO specialists across the globe feel today, that echo should be used more and more for ECMO today. In 2002, when we first started to use ECMO at AIMS, we used to use the roller pumps. And whether it was a veno-venous or a veno-arterial ECMO, depending on where the cannula is placed, is it going the access cannula from the vein back into the artery, such as the femoral or the aortic artery, or are we using a veno-venous ECMO mode as we do in COVID-19, where we are taking blood from the patient to the IJV and maybe returning it back to the RA or to the femoral vein, is a veno-venous ECMO, where the PO2 may not rise instantly, but it would be a good support given to the failing lungs. So whatever ECMO we use and whatever circuitry we use for the ECMO, echo becomes important to decide about the patient selection, to decide about the complications due to the circuit, to decide about the cannula positioning, and also to decide about the monitoring of the patient. The first ECMO was done by Dr. William Kolff, and this gentleman used the first synthetic membrane to form a gas exchange in ECMO. But it was in the year 1974 when baby Esperanza was born to a peasant woman from Mexico to the US, when she had landed in the hands of Dr. Robert Bartlett, the father of ECMO, who did the first successful ECMO, and baby Esperanza today is 54. And this cardiac surgeon brought home ECMO in a big way and still continues to do research on the ECMO circuitry. We have echocardiography monitoring on ECMO for the following reasons, and this is where my talk will outline: for patient selection, for monitoring the ECMO support, for insertion and correct placement of the ECMO cannulas, for detecting complications while on ECMO, for decision making and cardiac recovery, weaning, and bridge to transplant. When we use a mid-papillary short axis view transgastrically on TE and see small ventricles where the papillary muscles meet in the midline, it is a volume depleted hypovolemic state. So if we use this echo on using a probe which is, despite the heparin of infusion, put in very discreetly by the intensivist, and seen hypovolemia or seen hemodynamic disturbances, and seen a poor contractile myocardium which may need inotropes, or a tamponade which may need pericardiocentesis, or regional wall motion abnormalities which may detect ACS and intraoperative myocardial ischemia, or a pulmonary embolism due to the presence of an RV strain and raised RA pressures on echo, well seen, or if upper esophageal view shows a dissectic flap, then you know it's an aortic dissection, and this is a big absolute contraindication for putting in an ECMO. Aortic valve regurgitation, severe arterial vasculatory dysfunction are all relative contraindications to put in an ECMO because ECMO won't work. So when you're using a VV ECMO, then a lot of these contraindications should be taken into view. If it is a severe PAH, consider a VA ECMO rather than a VV ECMO. If it's a heart failure, again a VA ECMO and not a VV ECMO. So what are the views? The mid-esophageal modified bicable view that you see on the left panel, showing the position of the SVC, the interatrial septum, the LA, the RA. This is the whole of the RA, and the IVC on that side with the tricuspid valve here, or the short axis view of the LA, RA, the lower part of the IAS, the septal and the tricuspid, the anterior leaflet of the tricuspid with the RV here, and the RV outflow tract pulmonary valve here. So this is the RV inflow outflow view mid-esophagally, and this is the modified bicable view mid-esophagally on TE views, and these are good views to see and monitor the ECMO. The other views that are very important to see and monitor on ECMO are the four-chamber view, as well as the views of the LA-LV, the two-chamber view, the modified bicable view, and of course the tricuspid valve seen very well on the modified bicable view. You can see a IAS breaking here, and this IAS breaking here will be showing you the presence of an ASD. And when you see the presence of an ASD, then you know for sure that this patient is having a PFO or an ASD, and therefore doing a central VA ECMO is going to be a big no-no. So when you see these things happening, rule out these things happening by doing and selecting your patients judiciously. Mid-esophageal views, inferior vena cava, subcostal view on TTE, transthoracic apical four-chamber view on TTE are some views, and the parasternal views on TTE are some views which may not give you a very good view on transthoracic echo, but it will show you how and where to insert the cannulas and majorly the four chambers condition. ASD, interatrial septal aneurysm, a PFO, a prominent Chiari network, pacemaker ICD leads are a big no-no to forming an ECMO on the central VA ECMO. They are a relative contraindication. You should not put a central VA ECMO because here the ECMO flows will cause a decreased drainage. So this is what a Chiari network does. It causes obstruction around the cannulas, and therefore it's important to do a preoperative echo to select your patients well. Interatrial septal aneurysm again would do the same as would an ASD talked about earlier. Once you've decided that your patient is all right, does not have right heart lesions or any aortic dissection, does not have a malignancy, and we are going ahead and doing an ECMO, then insertion and correct placement of the cannulas is very, very important. And how do we use echo for that? So we use an echo whether transthoracically or transesophagally, using all four chambers, the morphology, the systolic, the diastolic function, the ejection fractions, fractional area change, velocity time integrals in the LVOT, E by A ratios, E by E prime ratios, and left atrial ventricular assessment with systolic function assessment. Look out for a McConnell sign for a pulmonary embolism. Look out for TAPSE for a RB dysfunction. Look out for a fractional area change decreasing, and pulse wave Doppler showing through the pulmonary valve an increase or decrease in the acceleration time. When you're seeing these, then see the right atrium and the vascular tree as much as you can using a Doppler flow or using an ultrasound with a TE or a transthoracic echo machine, and always use multiple views. Once you're doing the echo cannula placements, probably one of the best views is the bicable view, whether classic or modified. You go through the RA, SVC, then into the RA, and see the cannula resting well into the RA. And any migration or movement of this cannula will tell us a lot. Supplement the TE or the echo with an X-ray chest. And if you're using a multi-stage access cannula, look out for position or tip of the access cannula and the return cannula, always remembering that the access cannula would always be placed higher to the return cannula. An upper esophageal mid-chamber upper esophageal short axis aortic valve view is again a very good view to see the ascending aorta, to see the bifurcation of the innominate and subclavian, to see the position of the guide wire as it comes just short of the subclavian artery, and if you put it through the femoral artery. Interatrial septum, coronary sinus, tricuspid valve opening, as well as PFO are all well visualized, especially when you're using an Avalon double lumen cannula, where one lumen allows the deoxygenated blood to drain from the IVC and the SVC, and the second lumen allows the oxygenated blood to return directed towards the tricuspid valve. It reduces the recirculation seen with traditional VV setup. The venous cannula should be positioned in the mid-RA to allow optimal blood flow into the circuit, and peripheral arterial cannulas cannot be visualized. Only with a sonocyte ultrasound machine can you see them. Imaging of the guide wire in the ascending aorta using an upper esophageal short axis view of the aorta can prevent malpositioning of the cannula. You can see the cannula being inserted through the femoral vein here. This is the femoral vein axis cannula which is being put, and two people are putting the cannula percutaneously using the Seldinger technique, and as the main wire comes out, the flow is established, and if the flow is good, this cannula now cannot be seen with the TE machine, but you can see the opening of the IVC and the RA once the cannula tip enters through the IVC. into the RA, and then how it rests into the RA. So those are good things to see. And also remember that the multi-stage as well as the single stage cannula have a speckled appearance on the echo machine, and this speckled appearance can easily be recognized from the liver and the IVC into the RA. So this is Dr. Roberto Larusso is a very, very famous man, and this is one of his pictures that I've borrowed to show you how the opening from the IVC into the RA is being managed. Remember, the return cannula that comes back to the patient should be in the mid-right atrium. Access cannula tip should be in the proximal IVC when you're using the femoral vasculature. Echo is essential to check the position of any cannula across the IAS for PFO, for LA, TV, coronary sinus, recirculation, inadequate blood flow, and myocardial injury. Bicable lumen cannulas should always be seen in the mid-esophageal bicable view, and transthoracic subcostal view can be used to show the cannula in the RA, the tip of the cannula in the IVC, and the re-injection holes can be visible oriented towards the tricuspid valve. Always have a chart of list of subjects and organ chambers that you have to see through the heart, through the liver, the IVC and the hepatic vein, in the heart, all the 4 chambers and the septum, and any cannula position with the appearance of the pericardial effusion, the LVOT, VTI, the opening of the aortic valve, the S wave, the RV size and function, TR and RVSP should all be seen. Once you've seen the cannula, daily surveillance of the cannula is important, and so also monitoring during ECMO support. Now, when you're monitoring, especially a VA ECMO, remember something. There is a recirculation. There is stagnation of blood in the LV as time on ECMO goes on. Some ECMOs go on to 102 days. There may be back pressure changes of pulmonary congestion, edema, and hemorrhage. Myocardial injury affects the recovery. So there is insufficient unloading of the left ventricle. This would give rise to worsening of the MR as well as closing of the blood of the aortic valve and stagnation of blood in the ascending aorta. You can see this here. This is worsening of the mitral jet. This is the aortic valve in the long axis view, 4-chamber view, which is converted at 110 degrees to a long axis view, where you see the entire LVOT cavity. So this is the ascending aorta and there's stagnation of blood here. So this chamber needs to be unloaded. And how can you do it? You can do it by doing a balloon atrial septostomy. You can do it by taking the patient into the surgical OT and also doing a left atrial drainage or doing a left atrial return septostomy. Myocardial contractility, LV end diastolic volume, aortic valve opening, and mitral valve regurgitation are very well seen here. You can see the LV thrombosis and stagnation coming right till the LV from the aortic ascending aorta, and you can see the same on an M mode echo with the aortic valve not opening. So once you are seeing something like this and the regurgitant, you can see the regurgitation of the MR worsen across the LV into the LA, and if the LA jet becomes too full with the mitral regurgitant jet, then it's a severe MR, and this is a cavity which will not move too well, and an LV vent becomes imperative, either anterograde or retrograde LV unloading, using a atrial septostomy, using an IABP balloon, adding on to vasodilators as well as inotropes is all very important. But recent times, if we can't rush the patient to the cath lab, we use a left atrial appendage drainage. But see the thrombus, see the venous cast, and see this was a myocarditis which was unloaded, bridge to recovery. And this was another patient with a dilated IVC in the lower esophageal hepatic vein view with liver congestion and acute decompensation because of hypertrophic cardiomyopathy. When you see such situations, do a pulse wave Doppler before putting the ECMO, and you do it during the ECMO, and you'll see the flow going on very beautifully. +-2 is what is seen here. Remember to always hemodynamically monitor the patient with mixed venous oxygen saturation, increase in the coronary oxygen content. You should keep seeing an increase in your PO2 on the gases, increase in the ejection fraction, and decrease in the RV afterload. Detect the complications. They could be due to circuit, cannulas, bleeding, oxygenator, heat exchangers used all during ECMO. See the migration of small emboli from the LA into the LV, and see the akinesis of the LV. See any thrombus in a prosthetic valve which may be put in. We had one such patient here, which is very beautifully remarked, in which we developed SVC obstruction. IVC as well as SVC obstruction is very, very common. If you see an IVC or hepatic vein dilatation on lower esophageal view, it is an IVC obstruction. Liver also gets congested. See the Doppler interrogation for the flow across the IVC once the patient is on a peripheral ECMO, as well as see the Beck's triad, the swinging heart, as well as the raise in JVP, as well as fluid around the heart and the decompensation of the patient with pedal edema and enlarged liver. When you know something like this is to be done, then you decrease the ECMO flows. And once you have decreased the ECMO flows, you keep doing a 2D and 3D echo for the stuck valve and see any cast, any thrombi around the cannulas. Any oozing of blood around the cannula is going to give rise to thrombi. So this is where you need to decrease your heparin. And you can see here the thrombus has migrated in a in an RVAD that we had put across the cannula, and this was a worsening of the patient, and we took this patient and redid the cannulas all again in the OT. Balloon atrial septostomy to decompress the LA and LV is to be done. Septostomy for VA cannula is there. RV function may become very bad at the time of initiation, but as time goes on ECMO, it becomes better. You can use a BIVAD while on ECMO. You can, if you get such bad pictures like you do on a transthoracic echo, you could go ahead and use, after seeing obstructions, a definite contrast, and once you see a definite contrast on transthoracic, you do well. We have just a mortality of 74% at AIMS today. COVID, we saw nearly a 90% mortality, but what improved was the use of point of care testing and the use of echocardiography and the use of integrated ECMO. Do not start putting ECMO unless or until you're doing the ECPR. Do use ECMO in a selected manner as a routine case, and this is what we do. We put the patient on ECMO before the surgery for a atrial switch or a obstructed TAPVC or a Al-Kappa, so that they come off on ECMO. No time is wasted. It's all done under asepsis, and procedure is very cost effective with increases survival. We have had in the past with roller pumps tubing complications of rupture as well as loosening of junctions, and CPR had to be done, but ECMO was continued, and we've had a lot of publications, a lot of books written on ECMO to see where our complications was, but the triad of clinical judgment, hemodynamic parameters, and echo variables made us realize, and putting ECMO at the right time in a reversible pathology made us realize how to wean these patients off also at the right time. Ejection fraction more than 35 to 40%, end diastolic diameter less than 35, 55, velocity time integral across the aortic valve more than 10, aortic valve opening pattern and absence of LV dilatation. Decreasing VA ECMO support determines a reduction in LV afterload and increase in LV preload. Conventional echo recovery parameters are dependent on loading conditions. Use tissue Doppler interrogated non-loading systolic velocities of the mitral annulus by Doppler tissue imaging and find them to be of great value for predicting ECLS weaning. Pitfalls of echo in ECMO are there. Strong echo artifacts generated from wires and cannula during placement. Image intensifier in cath lab can be used to overcome this problem. Thomas et al. Studied the use of chest X-ray as an alternative, which was less operator dependent and easily available, but lack of radiopaque tips in some ECMO cannulas limits its use. No specific echo protocols are available for a weaning of VAD or ECMO. Weaning from VV ECMO relies on assessment of oxygenation and pulmonary compliance of the patient by decreasing the gas flow across the ECMO circuit and resuming ventilation on the ECMO blood circuit. Therefore, echo is not required. But echo can be used even in a venous ECMO at least once during the day to see the condition of the heart and supplemented with X-ray. Initiation of ECMO, cannula insertion, hemodynamic monitoring, and detecting complications during weaning is what would make echo very, very productive to the survival on ECMO. Echo is an essential monitoring tool in the care of patients on ECMO, and further investigations and guidelines should come up. We brought about the second edition of the book on ECMO. There are very few books on ECMO available worldwide from the TSS. This was the first book launched in 2014, and the second edition came out in 2018. We are shortly due for our third edition very soon. Dr. Robert Bartlett himself released the book along with our director, Dr. Guleria, our dean, Dr. Balram Arun, Dr. Trehan, Dr. Yatin Mehta, and many others. But it is writing books that we have reached where we are learning clinically and from our failures is what made us what we are today. Still a long way to go before we learn the perfect echo on ECMO. Thank you all.